Thank you very much, and good morning to everyone from across the thousands of miles, as it were. May I have my screen sharing, please? I'm very glad that I have this opportunity to share some thoughts with you, and I'm very grateful to Professor Bolton, with whom we've been collaborating for several years now. And I can see in the room my good friend, Dr. Abram Wagner, who too is part of the same team, and we worked a lot together in these recent years. So, hi, Abram. Perfect. So if all is well, I think you should be able to see this opening slide. It's just a few thoughts about vaccination equity. Some weeks back, or rather some months back, I had the opportunity again to share a few thoughts with you on this topic of vaccination equity. So I'm going to try and pick off from where I left off last time. And the first thing that I wanted to talk with you about is what's the cause of the inequity? Because my time is limited, so I'm just plunging into the topic straight. By and large, I think inequity revolves around two big, diverse kind of processes. The first is to do with vaccine delivery, and the other is to do with actually vaccination policy and decision making. Now, I must confess that I'm going to speak from the perspective of my country, India, but a lot of what I'm going to say is applicable to a lot of other low and middle income group countries, as well as developing countries in general. Now, some of these vaccine delivery issues include push factors like the system not making the vaccines available or affordable or accessible to the consumers, and pull factors, which means even if these are made available, affordable, and accessible, the community somehow doesn't reach out and grab them. Now, this little bit on making things accessible and to some extent affordable and available have been dealt with in great detail, and much of the focus on vaccination equity revolves only around this part of the story. In fact, a neighboring university in the US has got an international vaccination access center or some name like that, and their job is to try and make these things accessible. But the other side of the story usually doesn't come up in the discussions, and that is the part which I would think is more important, and that is policies on vaccination in developing countries and the decision making on vaccination, who should get what vaccines, etc., are often not made considering the local epidemiology or the local context. In fact, very often these decisions are made in an entirely different setting, sometimes in the USA, often in Geneva, and centers like that, not really even looking at what's going on in the country per se. And this kind of thing fosters inequity in vaccination choices, drivers of decision making. It fosters external and internal pressures by big universities, funding agencies, and even the WHO at times, and internal pressures brought to bear upon the system by these external forces, and these include professional societies and things like that. Industry, of course, is always interested to look for markets where their vaccines can be sold. If they're needed or not is a different question. And then most of these settings lack consumer empowerment. Consumer empowerment to make right choices, evidence-based choices, and decide what's the best mode of moving forward for them, as opposed to a hand-me-down decision from somewhere else. Now, a lot of this has actually been published in the supplement issue of the AJPM, which Professor Bolton took out in December 2020. And this little kind of review article that we wrote includes 3 case studies to highlight the story of 3 vaccines which came about in India into the national program, and what factors went in and how they've contributed to some kind of inequities. When you get time, if it is possible, please have a look at this paper, because it reveals some things which usually doesn't come up in discussions and publications per se. Now, this is the brief that Professor Bolton gave me. He said, I must think about what I wish a large leading university with multidisciplinary diverse groups of faculty and significant resources could do to address this problem of vaccine equity. And I think I'm going to give you one summary slide here, and that is this one. I think a prestigious body such as yours should look at a 4-pronged approach and not rely on only one of these prongs that I'm going to talk about. The first, of course, is to do a deep data analysis to look at the trends and the patterns which emerge from individual bits of data which are already available. This can be done safely from a university within the US. There is no boots on the ground kind of work. A master's student could pull out tons of data and get very, very rich kind of inputs for that. But if this is not complemented with the second part of the story, which is doing field studies with people on the ground, then it becomes a little bit of a problem, because while this first part is usually resulting in publications and things, The second part is actually needed to put the story between the data patterns and to collate it with what's actually happening on the ground. These two prongs would remain incomplete unless a prestigious body went ahead and did advocacy to empower the local community. And by empowering the local community, I don't mean, giving messages of health education and vaccine education to the public. I mean empowerment across all levels of policymakers, decision makers, consumers, and even these professional societies who actually contribute. And because I'm a provocateur today, I'm going to actually request this body to try and do preventive advocacy within the United States. And why I'm saying this word preventive advocacy is because we usually think that prestigious universities should make things more available and accessible. But I would say take a step back, look at things which are being pushed into developing countries which are not needed or desired by them, and then to try and prevent that from happening using the resources, using the reputation, and using the brain power that you have in your universities. And I think that's very important because a lot of universities have used many developing countries like research labs and built up reputations, publications, and CVs. And a lot of that stuff is really not in the best interest of the countries that we're talking about in this morning's speech. Now, having given this provocative thought or the four-pronged approach, I'm going to try and share a few practical ideas which we can look at. Now, the first one is, determination of vaccination status, because equity or inequity can be determined if we have robust data. In the Indian context, we have this thing called the National Family Health Survey Series, which is like an amalgamation of the district health surveys or, the process of getting the data on vaccination. So this has been done 4 times, in fact, 5 times. The data that we have in the most public domain is the one which was done in 2015-16. Almost 50,000 infants between the ages of 1 and 2 years were pretty much asked this question: what vaccines have you received at any point in time before the survey? And the data shows up like this. If you look at the vaccination status, down here below on the x-axis are the various antigens, the BCG, the 3 doses of DPT, coupled with the oral polio vaccine, and then the measles. There is some hepatitis B, but not as much. So you can look at these numbers. They are very encouraging and gratifying. They're all in the 90s, high 90s, in fact, except measles, which is probably in the high 80s. But it looks very, very encouraging. And this is based on looking at the vaccination card, which means when a child is given the vaccine, it's documented on a card. And these survey people went up and looked at those cards and got this information from there. So it looks very nice. But when they asked mothers of these children the same questions about the same vaccines, you can see a 20 to 30% gap between what the mothers recalled in terms of vaccination and what actually is written on those documented cards. And when you look for a vaccine like measles, that gap becomes almost 25%. For the 3rd dose of oral polio vaccine, it's a huge drop to almost 60%. And then the magic is that in India, they look at vaccination coverage by looking at either of these data. So these light yellow colored bars is actually what represents the vaccination status of children in India at present. So this last bar, which is showing 62%, is 62% of the infants have received all these vaccines at any point in time before their 2nd birthday. Now, naturally, this brings up the question, which data is correct? Obviously, one would think of saying that the card data is correct because that is documented, right? But then why are mothers not recalling vaccination of their infants? Is it possible that the vaccination cards are recording data improperly or overinflating the coverage estimates because people don't want to be seen to be not vaccinating their children? Is there something else going on? And I think that's where a strategy of deep mining of the data, coupled with looking at the data from the ground, by having actually field work done in settings where this is happening, is going to make a difference. So that is one thought for you. The second is, look at this issue of vaccination timeliness. Now, Abraham has published a very nice paper some years back on the fact that when we talk of vaccination and the proportion of children who received all the vaccines, we often fail to remember that these vaccines were not administered on time. So if you look at the pink bars over here, these are the vaccination coverage estimates, which is pretty much the same as what I showed you in the previous slide. But the green bars right next to them are the proportion of infants who receive the same vaccines on a timely basis. Timeliness is important because if you don't give these vaccines on time, During the delay period, the children might actually acquire the disease. So you can see that it is again in the high 90s for the first dose of TB vaccine at birth. There is only a 0.5 percentage difference between the people who got it at any time and the children who got it on time. But this starts to increase as the age goes up. And so you can see it becomes about 1% here, about 1% there, then 1.5%. And by the time you come down to the third dose of DPT vaccine and the polio vaccine, it's almost 2 percentage points. There is a steep drop of 10 percentage points in timeliness for the measles vaccine, which is given in India at the age of 9 months. And then if you looked at all the vaccines together, there's a clear 10 percentage points. Now, 0.5% might not mean much, but when a birth cohort is 26.x million, so 1 percentage point is actually 260,000 infants. So this half percentage point means 130,000 infants didn't get their birth dose of BCG vaccine on time. So it makes a lot of difference when we look at those numbers in the context of a population like India's. So again, the question is, why are these infants not being vaccinated on time? We're not going to get the answer for that from the data that we have from the DHS. We need to look at ground surveys. We need to look at field estimates. We need to contact parents in the community to find out what's happening. How much is the delay for each vaccine? Is the delay intolerable in the sense that the likelihood of an infant getting the disease is so much that delaying the vaccine beyond a certain point is meaningless? How does that impact on the disease burden and epidemiology? And of course, then what can be done to reduce this inequity? That was the second thought that I wanted to share. The third is, let's look at vaccination dropout. Now, this is 3 doses of the DPT vaccine, which is given in India at the ages of 6 weeks, 10 weeks, and 14 weeks. And you can see there's about a 10% drop in vaccination coverage as you go over these 8-week period. It's just 8 weeks between this dose and this dose, but about 10% of the infants now have dropped out and are not getting the last dose of that vaccine. Interestingly, at the same time that this vaccine is administered, the oral polio vaccine, which is just drops in the mouth, does not involve an injection, is administered at the very same sessions. So you can see that for the first dose, the OPV coverage is slightly more than the DPT. The same thing happens in the second dose. But then magically, by the time of the third dose, there is a drop in the oral polio vaccine coverage by almost 6 percentage points. So there is this stepladder decline, but the third dose of oral polio vaccine seems to be getting missed more often. And that's intriguing because we're a country which has, by the scruff of our collar, we managed to eradicate poliomyelitis. And this kind of a drop is really not going to be very, very favorable for the long-term scenario. So the question is this decline real? Is it artifactual? Because the numbers that we look at is going to show up data like this. We need to go to the ground to find out what's happening. Why is there a gap between DPT and OPV, considering that both are administered together? And why is the third dose of polio getting missed much more frequently? And does it impact disease burden and epidemiology and things like that? And then very importantly, is it time for a country like India to actually consider aligning our vaccination schedule for these 2 vaccines more with developed countries, which is usually given at 2-month intervals, unlike the WHO prescribed 4-week gaps, which is in most of the developing countries. That was my third provocative thought. Then here is something more interesting. When we looked at the data on vaccination inequities by birth order, this is a little complex chart. Let me try and explain it to you. The left side, 2 sets of bars look at the proportion of children who are fully vaccinated, and the right side bars look at children who are totally unvaccinated. Now, the first 4 bars actually represent data from the third NFHS series, which happened in 2005 to 6, and the next 4 bars represent the data from 2015-16. So the first blue colored bar is children who are first in birth order, then the second birth order or the third birth order. Green bars represent the children who are 4th or 5th in birth order, and the purple bars represent the children who are 6th in birth order or above. So it's very interesting that the higher birth order in a child is, the less likely he is to be fully vaccinated. And this nice little 10 to 20 percentage point drop is narrowed down in the latest vaccination surveys, but it is still there between 5 and 10% drop between each of these birth order things. And if you looked at the unvaccinated children, what we see is in the more recent survey, these numbers and proportions have actually gone up. That means not only are more children not being fully vaccinated, they are missing vaccines, but the higher birth order children are continuing to miss more vaccines. And this is intriguing because every other risk factor for vaccination, the notorious one being gender, seems to show a closing of the gaps. If you looked at the gender gap in the the third series in 2005 and 6, there was about 3 or 4 percentage point decline differences between boys and girls. This has nearly caught up in the 2015-16 survey. Likewise, the unvaccinated children proportion is also nearly caught up. So boys and girls are pretty much doing similarly as per the data. Likewise, if you looked at data by socioeconomic status, traditionally the lower socioeconomics and quintiles have less vaccination, the highest quintiles have better vaccination. So this step ladder pattern looks at the wealth as it is increasing. These gaps are also narrowed down in the latest survey, and the gaps in the unvaccinated group are also coming down. And similarly, for people who have the maternal education with lowest levels and the highest levels, there is a difference again, but these gaps are also closing. So intriguingly, it looks like the birth order somehow is working independent of everything else. And the higher the birth order, less likely is a child to be vaccinated. So the question is, why are higher birth order infants not being vaccinated? Now, it's interesting also to think that the survey was done only in 1 to 2 year old children. So these children who are of higher birth order may not belong to the same family. So it would be really, really interesting to see if we did a survey on the ground, what's happening to infants within the same family. Are there families which vaccinate their firstborn, sometimes vaccinate the second and third born, and then forget about the babies which came later in line? And if so, why is that happening? This would require not just epidemiology, this would require social scientists to get involved. And then again, does it impact on disease burden and epidemiology, and what can we do about it? Now, these are just a few random ideas that I've presented. There are many more, but the time being limited, I've just restricted myself to these. And I'd like again to look at that first question that was asked, what can we do together? And I think the key is to look at the data, and there is a lot of this data available in the public domain. Abraham, Dr. Bolton's group, and ourselves, we have been looking at this data very, very carefully. But the data is only going to end up as a publication of academic interest. It's not going to change much on the ground. To do that, we again need to do field studies with people on the ground who understand the ground realities. And this has to be complementing the data which has been mined to identify the trends and patterns. And when these two things are put together, then it's time to take it up to the decision makers within the country and community, which is including right from the policymakers down to the recipient of these vaccines, which means even families, to find out why they're doing things the way they do and what can be done to change. Meanwhile, I strongly again advocate preventive advocacy within the United States and developed nations. And that is because the focus is on industry-driven introduction of newer vaccines into the developing countries which can afford them, or which developed countries think are needed in the developing countries. A lot of it is not supported by data. So, you as a group, besides doing the first three things that I've tried to show on this slide, would also need to hold the horses, as it were, of other universities, funding agencies, prestigious bodies, which are trying to do things differently in countries such as ours. On that note, thank you very much for your attention, and I'm happy to take any questions. Thank you for that question. Now, when I say local community, the usual understanding is we're talking of the consumers of the vaccines, which is these families and people that are getting their children vaccinated. My definition of the community is much broader. I think it includes all stakeholders, right from the policymaker who's deciding a vaccination policy, who's deciding which vaccine is to be introduced in the country, who's going to get it, when they're going to get it, right down to the people who are going to implement the vaccination decisions, the professional scientific societies which advocate for these vaccines, and finally at the fag end, the consumer who's going to be the recipient of these vaccines. Why I say this empowerment has to be a chain process across all these stakeholders is because if only the community is empowered, then they might demand things which the system is not able to provide them, or they might reject things which the system is already providing them because of various factors and things like that. If you look at the scenario of the COVID vaccines, which are being rejected in several developed countries right now as we speak, it's because there is an imbalance in the empowerment. So the community feels that they're empowered enough to take decisions and actions which are completely contradictory to what the science is saying. That is not a real level of empowerment in which an informed decision making or an evidence based choice can be made. It is people, who are faddists and doing things on their own way. And because of the level of empowerment that is present in these countries, they can go and, shut down systems and block streets and things like that. That would be a dangerous level of empowerment. I think by empowerment, I mean that all people in the chain of decision making, from the policymaker down to the practitioner, down to the professional society, and ultimately the consumer, have to be empowered, providing the information that they need to make an informed choice, which is based on the science and the local epidemiology, not other considerations like commerce and industry push and things like that. Yeah, thank you again. I didn't catch everything, but I think the gist is whether that decline in vaccination coverage by birth order, which means higher birth order infants are not getting vaccinated, has something to do with vaccine access, the way healthcare systems have changed over time. Is that the question, right? Yeah, perfect. And I'm glad you picked up on that, because this is exactly what I thought, and I thought I'll try and map and see that at the same time that the survey was done, is there something different between the higher birth order infants and the lower birth order infants? The thing to remember is this is a cross-sectional survey. So they're not looking at a family and tracking their first, second, and third birth order infants. It is just picking up a bunch of infants and asking them, hey, what birth order are you? And noting down their vaccination status. So things are not changing over time because this is a cross-sectional one-point survey thing. The thing that I want to find out is if we did the survey on the ground and we went to families who've got more than one or two or three kids, then we would try and find out if the kids within the same family are having declining coverage rates as they grow older, which means if there's a family with 5 kids, how many vaccines did the first kid get? What about the second? What about the third? And is it true that this pattern exists within the same family? Because if it did, then there are two explanations for that. One is as time passes by, families are unlikely to see the consequences of these vaccine preventable diseases. They think they are less important. Things just get, slipped away from the memory. And at the same time, there is also a push for newer vaccines. So there is now the basic vaccines have been relegated to the background because there is no international company which is manufacturing or selling these in India. They're all local. But the big new fancy vaccines have come and taken over. So pneumococcal vaccine, rotavirus vaccine, typhoid conjugate vaccine, influenza, varicella, you name it. So it's possible that the infants, as they are, higher birth order, as the family socioeconomic status improves, are ending up getting some of those optional vaccines, what we call in India, which are much more expensive and delivered through the private sector, and hence missing out on these basic vaccines. But there's no way we can prove or disprove that till we actually get onto the ground and talk to families and see. But thank you for that question.